It's a pleasure of mine to introduce Dr. Janet Wright. Dr. Wright I've known for a number of years. She's now a born-again interventionalist, now on the prevention side of things. She works jointly, I guess, for CMS and CDC, and she's in charge of this Million Hearts initiative. So it's a pleasure to introduce her as the executive director, and she'll give us her insights. Thank you. Thanks for coming out.
It is a pleasure for me to be here tonight with my brethren. I have been living in a different land for about the last 6 weeks in federal land. It's entirely new for me. So it feels great to be back at home with practicing folks. So Million Hearts. Million Hearts is a unique approach by our government, by the U.S. Department of Health and Human Services. And it was the brainchild of Tom Frieden at CDC and Don Berwick at CMS, with pressure actually from the White House to do something very specific and meaningful that improved the health of the nation. And they looked around and saw that heart disease, of course, was the #1 killer, men and women, and there were dramatic disparities in cardiovascular mortality and morbidity. So they decided to start with heart disease. What this initiative is doing is bringing together the brain trust of community health and public health and science that exists at CDC, but marrying it to the Centers for Medicare and Medicaid Services, CMS, because there are a lot of levers that can actually help change behavior, whether that's at the individual clinician level or at the health system level, and even at the beneficiary level. So the work is going on across agencies. In full development over this next 5 years, it will go beyond the federal government to states and to private organizations, because we're trying to get really individuals to change their behavior. Small task. Maybe you guys can change yours. I was not good at it in my career, and I'm not very good at it for myself. But working really from the bottom up as well as the top down. So, those of you who have worked with Dr. Berwick know he doesn't play unless you declare a specific goal and a specific timeline. So we are about preventing 1 million heart attacks and strokes, and I mean we in this room, in the next 5 years. So the goal is there, and the two pathways are also there. The approaches will be to reduce the number of people who need treatment in the first place, obviously prevention. The second pathway is to optimize the care for people who do need treatment. We'll go through how we plan to have that happen. These statistics, you all could give these yourselves. The expense is extraordinary, and the disparities are just intolerable. The burden on our racial and ethnic groups are just basically intolerable in the U.S. So, the status now of the ABCs. So the initiative is focusing on aspirin for those who need it, blood pressure control, not just screening, but actual control, cholesterol control also, and smoking cessation. Now when I first heard the ABCs, I thought the A would be for A1C or physical activity, not for aspirin. But the science crew that's been looking at this for over a year believes that we can make the greatest impact in the shortest period of time with really excellence in aspirin adherence. You see we're not performing where we want to be. Everything's below 50%. Those are all population numbers. So, again, going back to those two lanes or avenues of approach, there'll be a clinical prevention side that's looking at the ABCs and a community prevention side. I will tell you already, I've noticed a difference in the tribes, in the breeds of cat that I have gotten a chance to now sit with. When I talk about smoking cessation and, not smoking cessation, but smoke-free environments and sodium reduction, trans fats reduction, I can almost pick out in the room who's a public health officer, because that just makes them twitch. They are just all over that and excited about it. It's a little alien to me as a practicing doc. It just feels too big and kludgy. I don't know how I'm going to do that. But on the clinical side, most of us sort of are pretty interested in getting an A in the ABCs, even at the specialty level. I don't know if it's true in your community, although primary care docs did do a lot of treatment of the ABCs. we were probably not doing the kind of job that we would like to do. And so, looking at the clinical prevention side, we're breaking that down into three main approaches. The first is to focus on aligning and simplifying the measures so that the measures are measured the same if you work at Geisinger or Kaiser or if you have a private practice. And when you look at all the alphabet soup that gets its hand in measurements, we're trying to get those all aligned and measured the same way. That is no quick job, but there's a core set of people working across the government and the private practice settings to help coordinate that. And then the thing that we can do clinically is to actually emphasize the power of ABC performance on outcomes. The fact that if we got all of our patients who should be on aspirin on them, got their blood pressures controlled, or even just way better than it is now, same thing with the cholesterol, and get more people to stop smoking, the dramatic difference in the risk of heart attack and stroke occurs over a pretty short period of time. So the power is actually in our hands to make this happen. The second bucket or domain of work, 4 million hearts, will be in health information technology. And fortunately, one of the people earliest on the Million Hearts train was Farzad Mostashari, who is the national coordinator for health information technology. His work has gotten the ABCs embedded into the criteria for meaningful use. Part of it will be in stage 2 and more in stage 3. So the idea is, I don't know about you, but I never knew how my population of heart failure patients were doing. My practice didn't have an electronic medical record. They have one now, got one after I left. But there was no way to track a population, and most of us take care of an individual patient one at a time. But when it comes to moving behaviors, there are a lot of behaviors that you can move as a group that you might not move individually, and you need to know how many of my folks are on aspirin. So HIT is critical for that. It's also critical for quality improvement. You can do it with a pen and a piece of paper and a stack of charts, but when you have an electronic medical record, your QI processes are easier. And then the behavior change, whether it's at the doctor and nurse level or at the individual patient level, are greatly enabled by the kind of reminders that electronic means can deliver for us. The third bucket under clinical prevention or care innovations. I know that the cardiac rehab nurses in my program in Northern California were much more effective at changing someone's behavior than I was. I actually kept a page in my top drawer in my office of the number of people who came back after my haranguing them or cajoling or being a cheerleader. I kept a list of the people that actually changed their behavior after I talked to them. And I was in practice there for 23 years. And I still had just one page. And I would ask them, why then? Why now? Did I say something? Was it in you? And most of the time it was 90% something in them and maybe 10% that I said. But it was never the same thing never the same thing twice. So there are people who understand behavior change, and they're experts in that. And there are also settings where that is more likely to occur in the relationships, for example, that are built in cardiac rehab settings. So we got to get the right instrument for the right job. And then we're learning more and more about med adherence, but we definitely have a long way to go. There's some HIT facilitation that can help with med adherence too in our e-prescribing technologies. So at the community level, we're focusing on reducing exposure to smoke-free environments, getting sodium and trans fats out. I had a really fascinating experience Friday. I sat in as a guest and the Million Hearts presenter with the AHA's Industry Nutrition Advisory Panel. So these are like 40 of the biggest food companies in the world. And I asked them, if people went out today and bought their lower sodium and no trans fat product, how soon would that company know that those products were going off the shelves? And they said basically in a matter of a couple of days they would know. And they're not going to make the products if they're not flying off the shelves. So there's kind of a chicken and egg thing going here, and through, I think, concerted effort, again, both top and from the bottom, we'll be able to move that needle. Okay, so you all know this, that folks can really reduce their risk of heart attack and stroke by taking that aspirin regularly. Quick drop in mortality from stroke and heart attack with blood pressures that are controlled as cholesterol as well. And then clinicians are, I don't know if you feel frustrated, I very often did, but we are powerful movers when it comes to helping people stop smoking, especially if we can follow that up with the provision of medications and other counseling support. So you're probably familiar with this study, but the CDC, it's kind of part of the thinking around Million Hearts is if we were able to apply the controls to the conditions you see there in the populations that required it, we really could save a dramatic number of lives, and again, in a fairly short period of time. So part of what Million Hearts is about, as I mentioned, is getting these incentives aligned so that the measures for the ABCs are embedded in, say, the PQRS program, the Physician Quality Reporting System, so that docs actually get recognized and actually reimbursed differently because they are applying those or measuring those ABCs. Same thing is true with the meaningful use criteria, and you see the other examples here. I just, over the last 48 hours, have been putting together a report for the first 6 weeks of Million Hearts to deliver to the Deputy Secretary tomorrow. And I didn't think it was going to be that hard to do, but then I started amassing details of all of the programs across all of the federal family, and there's an enormous amount of work going on. So I believe that this goal is audacious, but I also believe, especially if we can hook it up to the private organizations and down to individuals, we'll get there. I would also say that the federal government chose heart disease first, but that if this kind of focused approach works, other conditions will most likely be sent down this same multi-stakeholder kind of platform. I kind of covered the HIT aspects, and I am a firm believer in the theme-based care, so this Million Hearts work definitely resonates with me. Here's an example of a study showing how the impact of pharmacists, and at least in my practice, we did not take advantage of pharmacists. I know in many hospitals now, pharmacists are rounding, and they're much more an active part of the team, but they clearly can have an impact. So we're trying to articulate what does each level of that multi-stakeholder community, what can it do? And within the medical system, there's clearly a role for the healthcare providers of every stripe, pharmacists certainly, and insurers to make sure that those measures are aligned and they're incentivizing adherence for their member and also for the physicians involved. And then a lot of the responsibility comes back to the individual. And what's so important about Million Hearts is not just to get out a message that everybody knows, that high blood pressure, high cholesterol, smoking is bad, but what do I as an individual, what can I do, what steps can I take today to change that? Tobacco prevention, major focus there at CDC, but there's also additional benefit now or additional attention from FDA, and you will soon see some radical advertising, mass media campaigns, more dramatic and explicit than any I've ever seen coming out of CDC. That, in fact, is one of the things that drove the smoking rate down in New York City. This is a slide that gives us all hope that those marked declines you see were a composite effect of, one, taxing cigarettes at both the state and the city level. The second decline was caused by policy, smoke-free environment policies. And the third was a mass media campaign. And the red line are the adults' percentage of smokers, and the blue line are youth. So it can happen. Sodium, I don't know what we're having tonight, but for most of us, we're getting in way more than we need. And I only bring this slide up to show you that, again, the federal government and the federal family is taking a multi-pronged approach. Trans fats. The take-home message here is that as soon as trans fats started being displayed on labels, the companies started taking the trans fats out. There's been dramatic change in a really short period of time there. So across the community, we again are trying to identify and articulate what each group could do and how, working together, we can get there sooner. I had to laugh. There was a meeting November 1st in DC of some new partners in Million Hearts. The Association of Black Cardiologists, American Heart Association even extended its commitment, and the American College of Cardiology, along with additional groups. But I was fearful. When Jack Lewin got to the microphone, I knew he was either going to say we were going to save more than $1 million or we were going to do it in a shorter period of time, and I'll be darned, he did both. So nothing like continuing to challenge us. On the community level, over $100 million just went out in prevention grants to 61 communities around the country. Some of these are likely in your homes. They are mandated to address high blood pressure and high cholesterol, along with the other factors that you see. These are 5-year grants, and we hope to see a lot of connection at the community level between the beacon communities that are getting electrified and these community transformation grants. So almost at the end, you see these again are population level, population-wide numbers. You see where we're performing at baseline, and by 2017, that's where we want to go. There's a lot of reason for hope, and on this slide are just 4 different communities, all that looked at focusing on a specific problem, and you see the numbers jumping, whether it's aspirin intake at the HRSA community through the community health centers, Kaiser, Colorado focused on cholesterol control, Rhode Island on blood pressure, and in Massachusetts, the Medicaid population dropped their smoking rate again in pretty quick order. Lots of support on the federal level and lots on the private. We have a doubling of those numbers of partners and looking for more. So I know that the mission of SHAPE and mission of Million Hearts are completely aligned. You all are dedicating your work to preventing heart attacks and strokes. I just want to express my appreciation for that. I will be following your work. I hope that it accelerates the goal that we both are seeking, and hope to have further conversations with all of you about Million Hearts. Thanks.
Like I said, we are going to go ahead and break now, so everybody can get their dinners, and we'll be back to you in a little bit. We'll kind of see how long it takes for people to go through, but we're a little bit behind, but we'll get there. Thank y'all.
Dude, come here, look at this. It looks fuzzy. I'm hoping it's not fuzzy. No, it might just be the LCDs. Yeah, it's not helping. But this is not an HD camera. No, no. But it should still be. Yeah, yeah. But anyway, we're going to load it on the website.